So thank you, Dr. Godwin, Hillary, my friend and colleague for many years. And one of the things she mentioned in my introduction is about the way the language I use in my articles. And I think as health equity researchers and advocates, it's very important that we move away from what is sometimes the very bland language of research and call out inequities when we observe them. And I try to do that in my titles of my manuscripts and the way I write up my manuscripts, because I think if you want your work to have action, if you want them to be able to translate to action, I think you have to frame them in an activist framework and use activist language. So that's one of the reasons why I do that. And I actually haven't been doing it my entire career. I just started doing it maybe about 10 years ago. But before we start, I want to ask you guys, where are you from? So where are you guys from? And don't just say, you know, the University of Washington, but where are you from? So where are you from? Yep. Okay, you're from Guadalajara, all right. Hillary, where are you from?
Complicated, but born in Michigan and grew up in Southern California.
Okay, so you're from the Midwest. Jeff, where are you from?
Grew up in Texas, but left at 22.
Okay, Texas. Anybody else? Where are you guys from? Where are you from?
I was born and raised in the Philippines.
In the Philippines. You know, so my dad was in the military, and when I was 2 weeks old, they moved to the Philippines. He was stationed at an Air Force base there. And when I worked at UCLA, I had a staff that was mostly Filipino, and I used to tell them, you know, I was eating lumpia long before I was eating burritos, and they would always laugh and think I was stupid. No, but my family's from a little town called Las Vegas, New Mexico. They like to say they're the first Las Vegas. It's a little mountain town in northern New Mexico. It's 77% Latino, 52% speak Spanish, about 20% have at least a bachelor's degree. It's high rates of obese and overweight. Only about 48% report having a healthy diet. 90% report drinking alcohol on somewhat of a regular basis. It's a very high rate. This is, of course, among adults. And the average household income is about $34,000 a year. And so sometimes I get asked, you know, why do you do health disparities research, and why are you focused on Latinos? And a lot of it comes from just my family background. So my grandmother had 16 kids, but 8 of them died in infancy. I have, you know, also in this town, there's just, you know, this town is ripe with health disparities. They have a lot of substance and drug abuse, and I have 2 uncles who died of overdose. So I come from a family with a lot of health disparities, you know, a lot of diabetes, all of that, cardiovascular disease. Both my grandparents died of strokes. So it's something that I'm very familiar with. Now, I'm going to put this, I'm not going to walk around, I'm just going to put this here for now. All right, so you guys in this audience, you are all, you know, sounds like you guys are all health professionals, nursing, public health, social work students. So you probably have heard this, that the Latino population is dramatically shifting, right? It's growing. So you can see just from 1970, which is around when I was born, you only had about 9.6 million Latinos in the United States. Most of them were concentrated in the West and Southwest. And now in 2018, with the latest census, it's closer to 60, I'm sorry. And by the way, feel free to stop me at any time. So I'm gonna start off with just some demographic stuff, and then I'm gonna get into some of my research. But feel free to stop me, because I'm happy to clarify, happy to elaborate, happy to go off on tangents. I'm happy to do all of that stuff. So when you look at Latinos compared to other demographics in the United States, it's a growing population. So right now, Latinos make up about 18% of the U.S. population. And it's expected by 2065 that number will go up to close to 25% And also, an emerging population are Asians, Asian Americans in the U.S. But Latinos now compose the largest group of racial or ethnic minorities. And we hear a lot in the literature now about, especially since the 2016 election, a lot about undocumented immigration. And the reality is that long before Donald Trump, sorry to call him out by name, but I'm not employed here, so I think I can do that, came into office, the number of undocumented immigrants into the U.S. has been declining. And interestingly, the average stay in the United States for undocumented immigrants is now around, it's more than 10 years. So 66% of unauthorized immigrants have been in the U.S. for more than 10 years. So this notion that, that the undocumented, it's a recent phenomenon, that they're low acculturated and all of that is somewhat outdated. In fact, I have a paper out view right now that has shown that the undocumented actually do not have patterns of acculturation and health like you see with recent immigrants, that they actually, the average undocumented Latino immigrant has health behaviors that's very similar to mainstream Americans. And so that so this notion that the notion of the healthy immigrant effect for undocumented immigrants doesn't really hold, although it does for some women and on some behaviors. And then the other thing I wanted to show you here is that immigration from Mexico has also decreased, which isn't so surprising. Now these data go up to 2016, and if I had data that actually spread out to 2019, the numbers would still be declining. But immigration from Latin America has mainly been coming from other places than Mexico, where early on it was mainly from Mexico. Now this is the percent of the population that was Latino or Hispanic in 1980. So not too long ago. I know some of you might have been born back then, but this is what it looked like. So there are large concentrations of Latinos in the West and the Southwest, which isn't so surprising because that used to be Mexico, right? In fact, people, so I showed you earlier that I was from New Mexico. That was once part of Mexico. And people oftentimes ask me when my family immigrated to the United States, and I always tell them, well, we didn't immigrate. We were there. We were colonized after the Mexican War. And you can also see New Mexico, which is that really dark blue area right there. High proportions of Latinos. Go back 300 years. Now, in 2014, the demography has changed a bit. And so now you're starting to see Latinos in areas where there were no Latinos in 30 years ago, 40 years ago. And particularly in the Northeast, in the South there. But you also see Latinos growing up in areas like Nebraska. And I actually gave a talk a few months ago in Lincoln, and I was showing some similar data, and I said, and even in Nebraska, you guys have Latinos, and they were laughing about it. But one of the things is that and also Washington, Washington State up there, so now you have, I'll go back, this is what it looked like in 1980, 40 years ago. This is what it looks like now. So certainly seeing a lot more Latinos in the United States. Now, in terms of the heritage groups, so Mexicans, not surprisingly, because of the U.S. history, make up the largest proportion of Latinos. That is somewhat shifting. Followed by Puerto Ricans. And I do not believe the Pew data include the 3.5 million Puerto Ricans who live on the island. So this is just Puerto Ricans on the mainland. So if you include Puerto Ricans on the island who are also U.S. citizens, that percentage would be a bit higher. Followed by Cubans and Salvadorans. And then, the notion that Latinos are all Spanish speaking, or that Spanish is the common factor that defines culture or heritage for Latinos is quickly changing. And just as an anecdote, so I grew up from New Mexico, but military brat, lived in the Philippines, lived in other places, and my parents both spoke Spanish. My mother speaks Spanglish, really. My dad speaks Spanish, but he can speak it, he can't write it. But their parents were fluent, and then mostly in speaking but not writing, and then their parents were both fluent in speaking and writing. So my family has certainly acculturated over generations. But this, and so when I was on the West Coast, that's a very common story among Latinos on the West Coast, especially in California and the Southwest, where many people my age and younger don't speak Spanish well. And in 1992, I moved to Pennsylvania for the first time. It was the first time I'd ever been east of New Mexico. And I lived in Philadelphia, where I live now. I actually had lived there in the 90s, moved away, and then now I'm back again. But it was striking to me that people would challenge my Latino ethnicity. So I would tell the people, say, well, where are you from? Because I looked different, but they couldn't really place me. And some people thought I was Italian, but they really couldn't. Maybe you're Puerto Rican, I can't really figure it out. And I would tell them I'm Latino, I'm Mexican heritage, and they would immediately say, no, you're not, you don't speak Spanish, you don't have an accent. And it was very, for me, it was kind of traumatic because, it's like, why would you not think, and why do I have to defend my ethnicity? But that was just what they were used to in terms of the emerging Latino population in the Northeast at the time. Most people who were coming into the region were immigrants, or they were migrating from Puerto Rico, and Spanish was a primary language for most Latinos. It's now changed since I moved back. It's much more Latino than it had been, and there are a lot of English-speaking Latinos in Philadelphia and in Pennsylvania. But you can also see that that Latinos in the U.S. are quickly acculturating, at least in terms of language proficiency, speaking language at home. So now I just want to, so that's just a little bit of background, and now I want to get a little bit into my work. So before we get into, I'm going to talk mostly about healthcare reform and population health, but I just wanted to give a little shout out to a grant I recently got from NIH to study psychiatric and substance use disorders post Hurricane Maria in Puerto Rico. And I've been doing work in Puerto Rico for 21 years now, and we have a cohort of about 3,300 Puerto Ricans who we surveyed. It's a probability sample, household sampling, all of that good stuff, island-wide, that we surveyed about a year before Hurricane Maria hit the island. And we just so happened to have surveyed them on all the psychiatric and substance use disorders in the DISC. And now, so then the hurricane hit, which provided a unique opportunity to look at the longitudinal development and exacerbation of psychiatric disorders after a major hurricane like Maria, which really doesn't exist in the literature. I mean, most of the post-disaster work that's been done has been after, post-disaster, and then people are asked to recall their experiences or their psychopathology before the hurricane. And as we know, there's something in psychiatry called telescoping, which is, when you ask people after an event to recall things before the event, before a disaster, they will attribute symptoms to the event because that's what they're thinking about. And so that creates a lot of bias in determining psychiatric disorders post-event. And we're looking at things like resilience, so those who didn't have psychiatric disorders before the hurricane and continued not to have psychiatric disorders after, and then how they differ from those who had psychiatric disorders and continued, and those who didn't and then did. And then we're also asking, in addition to a bunch of other questions, we're asking about the governmental response and how the lack of the poor governmental response to the event, to the hurricane, impacted psychopathology on the island, as well as their experiences to the hurricane. So I think there'll be some interesting stuff that comes out of this study. We're really looking forward to it. We're currently in the field. And the other thing about the study is we're able to follow Puerto Ricans who've moved off the island after the hurricane. So we're actually doing household interviews in New York and in Florida, and I'm sending my staff from Puerto Rico out to do those investigations. Now let's get into the ACA. So the ACA is a hot topic right now. It has been for the last 10 years. You know, the ACA is 10 years old now. Well, almost 10 years old. I was talking to my undergraduates about the ACA recently, and they just looked at me like I was talking about ancient history. And I said, well, how many of you, where were you in 2010? And they were in elementary school. So just to give you a little bit of context. So this paper came out in 2016 with my colleague Jia Chen at the University of Maryland. And we just wanted to know, it's a simple question. So how has the ACA impacted healthcare disparities? So have we seen a reduction in healthcare disparities, particularly between non-Latino whites and non-Latino blacks and Latinos? And what we found in this study is that actually things have gotten better with the ACA. That we saw improvements in access. Of course, we've seen improvements in insurance coverage. We have seen improvements in accessing care as well as utilization of services, and that the disparities have been attenuated. However, of the groups, Latinos continued to fare worse. So while they improved in access and utilization, and while the disparities were attenuated, Latinos continued to fall way behind. And I'm just going to show you, I wanted to show you, these are just, you guys can go to the paper to find out look at all the adjusted analyses if you want to. Basically, the patterns are the same for the unadjusted, so I just figured it'd be easier to demonstrate the unadjusted analyses for you here. So what you can see here, so this is the probability of being uninsured pre and post the Affordable Care Act. Now, I have to tell you, so these data for this paper, these data go up to 2014. So just as a footnote to this, so the law was passed in 2010, but it wasn't nationally implemented until 2014, although some states, in particular California and other states, started implementing some provisions of the ACA before 2014. So this is going up to 2014, and I have some later data, some more current data in a bit I'll show you. But what you're seeing here is that the trends of uninsurance are going down, but that there are disparities. So what you're seeing here is that, so for all groups, doing better, but for Latinos, they fare much worse than the other groups. And this is looking at the probability of delaying any necessary care. So again, it's good for all groups, although for African Americans in this case, they're the ones who do worse. But Latinos are right behind them. And then the probability of having any physician visit, all groups are doing better, but Latinos fare worse. And they continue to fare worse. So then we were interested, okay, well, we know when we look at Latinos as a monolithic group, they don't do so well compared to the other groups. But is that true for all Latino groups? And so we did another paper working with a former PhD student of mine, Hector Alcala, who's now at Stony Brook. We decided to disaggregate the data by heritage group. And we looked at Puerto Ricans, Mexicans, Cubans, Central Americans, and this amorphous other Latino group. And what we found was that, the ACA has reduced gaps in access and utilization, but that most of the reductions were experienced by Puerto Ricans, which isn't so surprising because Puerto Ricans are US citizens. And they don't have the same issues around citizenship and documentation status and eligibility that other Latinos, particularly recent immigrants, have. So in case you guys don't know this, so in most states, immigrants who've been in the United States for less than 5 years are not eligible for any kind of federal benefit. And that's a result actually of the Clintons in the 1996 Welfare Reform Act. And that we found in this paper that there were remaining disparities. And I'm just going to show you, again, I'm showing you some of the unadjusted analyses here. Trends were similar when we adjusted. And the take-home message here is that Mexicans and Central Americans fared worse than the other groups. So in terms of looking at, so we flipped this, because I thought it was, at the time, it was easier to, so the question in the data is uninsured. We flipped it to talk about insured. But you can see that the trends for insurance coverage goes up for all groups, but there are disparities according to heritage group, where Mexicans and Central Americans do worse. And the Puerto Ricans do pretty well. Again, looking at any delay in care, so trends are actually getting better. So there are fewer people delaying necessary health care, but I mean, it's a little bit noisy over there, but there are some disparities. And then this is foregoing care. So this is just not getting any care at all. Same idea, trends are getting better. So for Latinos in general, everything is getting better after the ACA, but there are some disparities according to group. And then this is looking at ED visits. And this is interesting here. So while Puerto Ricans were doing better on insurance coverage and all these other access and utilization measures, they actually were much more likely to use the emergency department. And we couldn't really get into the data because the data don't really allow us to understand why that's the case, but we can speculate. And some potential hypotheses around the quality of care that Puerto Ricans are receiving, both, particularly in New York and the Northeast. The systems of care might be of lower quality, less accessible, particularly around language concordance, accessibility, and providing information to patients about what services are available to them. Also, you guys, again, I don't want to say things that you might already know about, but the ACA, something that we don't talk a lot about with the ACA is that much of the increase in enrollments after the ACA have come from Medicaid coverage. So particularly among the very poor. And Puerto Ricans are much more likely to be on Medicaid, and we know that than some of the other groups. And we know that from other studies we've done that physicians post-ACA are less, even though Medicaid is now reimbursing at higher rates post-ACA, a lot of physicians still won't take Medicaid. So even though you have insurance coverage now, doesn't mean that you will have access, doesn't mean that providers will take your insurance. And that's not only true for Medicaid, it's also true for people on the marketplace exchanges. We have shown that in other studies that physicians post-ACA are less likely to take patients on Medicaid and on marketplace exchanges versus those who are on employment-based insurance or those who have just bought a private insurance plan off the marketplace. And it's actually something we don't talk too much about because the media mostly focuses on the marketplace exchanges. And in fact, right now, I don't know if you guys know this, but I think it's something like 14 states are suing, and it's in the courts right now to try to get rid of the ACA, with Texas, which has a high proportion of Latinos, by the way, and has the highest uninsured rate of any state in the country, is the lead state in this lawsuit. And states that have decided to expand Medicaid are all now freaking out. The governors are freaking out because those states that have decided to expand Medicaid, the federal government's picking up most of the tab of Medicaid now. And so if you get rid of the ACA, the state's going to have to pick up that tab or get those people off the Medicaid rolls. And as we know, once you provide people with insurance coverage, and then you try to take it away, constituents aren't going to be very happy. So the states are now trying to scramble to figure out, especially those states that expanded Medicaid, try to figure out what they're going to do with Medicaid, also with the marketplace exchanges. So this is something to follow. This is actually recent. This is a recent thing. All right, let's get back to the data. So this is looking at any physician visits. You know, as you can see, there's some disparities. They're not great. The one thing, this is probability of having any physician visits. So just so you guys understand the data, so these are probability data. And then in the paper, we wanted to look at, you know, does citizenship and Spanish language use affect any variability? And of course, we find that non-citizens compared to US-born Latinos. So this universe is just Latinos. They had lower odds of being insured, lower odds of visiting the emergency department, lower odds of seeing a physician, which probably isn't too surprising. And then also similar patterns for Spanish language use. So we wanted to figure out, all right, so we know so we've seen these trends for adults. So we've seen, you know, positive effects on access and utilization post-ACA, but do these associations hold for kids? Now, the ACA was not designed to target kids, but they are indirectly affected through their parents. So once their parents have Medicaid and they have a marketplace plan, or, you know, their kids are much more likely to be covered through Medicaid or through CHIP. And so what I just want to show you here, so this is just looking at the child population by race and ethnicity. So right now, Latino children make up about 25% of the total child population. So it's about 1 in 4 kids in the United States are Latino. And that number is growing. So this is some pre-ACA data. I'm not going to spend too much time on this because this was pre-ACA, but this was a paper that Alma Guerrero, a former trainee of mine at UCLA, she reported in medical care. So she just wanted to know, do Latino children have worst experiences in care? So do Latino youth and families have worse experiences in care compared to other children? And not shocking, we found that they reported worse experiences. So they were less likely to report having family-centered care on these 4 components of family-centered care. And this is another paper by another trainee of mine, Brent Langelier. He did a decomposition method to try to figure out how much of observable factors can explain disparities in healthcare for kids. And you know, similar to the adult findings that I showed earlier, Latino kids were less likely to have a usual source of care than white and African American kids. They were less likely to have preventive visits to see a doctor, and they were more likely to have delayed care. And the disparities were largely explained by socioeconomic status factors and health policy factors. So this is important because these are mutable. Health policy factors are mutable. So we can do things with health policy to try to assuage the disparities. Now, similar to the previous studies, we wanted to know, so okay, we see these monolithic, you know, Latinos as a homogeneous group. Do we see the subgroup differences? Just like their parents, we see similar patterns with Mexicans faring worse. In these data, we didn't have Central Americans, but we did have Mexicans, Puerto Ricans, Cubans, and others. So the Mexican kids did worse, just like their parents, which may not be so surprising given immigration patterns, particularly before the ACA. And the one thing that I'd want to point out here is that in the multivariate analyses, these disparities, as is the case for the adults, could not be explained away by insurance coverage. So utilization disparities it's not just a matter of not having insurance. So even when you account for having insurance and other important factors like family income and family education level and geographic location, we still see these disparities. And more importantly, we see these disparities after accounting for need. And then this is another paper came out a couple years ago looking at experiences in care. And so we just wanted to know, similar to the adult literature, do we see differences in children's experiences in care according to their parents' citizenship status and language use? And probably not so shocking, we found that there were disparities. Although there were no disparities in access, there were disparities in experiences. And one thing I have to say is that in terms of the kids' literature, most kids have insurance. So it's something like, and this is nationally, and these are, I believe these were CHIS data. In California in particular, California has very flexible and progressive health policies, but even nationally, most kids have health insurance. So you don't see big disparities in things like insurance coverage, but you do see differences in disparities in things like having a regular provider, number of provider visits, having access to preventive care, and all those things. And also when we looked at, this was just a simple question, do they have different experiences according to these factors than they do? And that's a big problem, especially in California, which has such a large Latino population, and we see disparities. And this is looking at insurance coverage and Latino youth. This is so much like their parents. So this is now. So what I've shown you up to now has been pre-ACA. So this is looking at pre and post ACA, and so we see that. For all kids, and I'm going to show you some of this data here. So for all kids, insurance coverage has improved, but that we do see disparities for Latino youth. So Latino youth did better, but they still fare worse than the other groups. This is looking at well child visits. So this is having things like immunizations, having screenings and that sort of thing. All groups did a little better. I mean, you can see that these are small differences. One of the things I have to remind people about is that when you're looking at differences of like 2%, but when the denominator is millions of kids, that's actually a lot of kids. So that's one thing to keep in mind when you look at these bar charts. You can see here for had an ED visit for in the past year. There was really no differences pre and post ACA for Latino kids. There was a slight drop here for African American kids. Really no difference in having a physician visit. And then we had this is like the former analysis. We wanted to break it up by heritage group, and lo and behold, what do we see here? That the Mexican kids and the Central and South American kids do worse than the other groups. Although they have improved over time like everybody else, they still lag behind. And then this is looking at well child visits in the past month, and same patterns that Mexican kids and Central and South American kids don't do so well. ED visits, now again, like the adults, the Puerto Rican kids are going to the emergency department. And so there's still an unanswered question about why that's the case. So you see improvements in insurance coverage and access and primary care utilization, but they're still going to the emergency department. And there's actually a fallacy in the health services literature that primary care is a replacement for ED. So if you give people primary care, that's going to move them away from the emergency department. And we know for certain segments of the population that just isn't so. You give them primary care, they're going to go to their primary care, and they're still going to go to the emergency department, either because it's about a perception of availability and accessibility or convenience, or it's because what they understand and know about the health services system. Just anecdotally, with my family, when I was a kid, my mother never made primary care appointments. If we got sick, she just rushed us to the emergency department. Like the notion of you have a primary care provider who's kind of responsible for the health of your kids, and it's supposed to be comprehensive and continuous and coordinated, just was not something she knew about, thought about, heard about, any of that. So the idea of of the hospital or as a center for care was really through the emergency department. You had a question back there.
Where are you in that categories there, your family? Where is your family in those groups?
So my family would be Mexican heritage. Yeah, so my family were U.S. born Mexican. Yeah, so they were born in New Mexico, Las Vegas, the first Las Vegas. All right. And then, so really no big patterns here other than Mexicans. Again, when looking at physician visits, which is a little different idea than well-child visits, they fare worse. Now, one thing I wanted to point out here, so we have a recent paper out. It's so recent that it doesn't even have a date or a volume yet. It's still in press. We wanted to know, so 2018 NHIS National Health Interview Survey data came out. That's what we were using for some of those prior analyses. So we were interested to know, are we still seeing improvements for kids, and do Latino youth still lag behind? So this was what they called a progress report. So we analyzed the data using the newly released NHIS data. And what do you guys think we found? I'm not going to show you the slide yet. What do you think? So this is for kids, the kids' data. Anybody want to take a guess? So in terms of the trend, so remember, using the earlier data, the 2016 NHIS data, we saw that the trends for all kids in terms of insurance coverage and well-child visits improved, but then when you broke it down by racial and ethnic groups, Latinos fared worse, right? They lagged behind. So now we have the new data. So do you think the trends continued? Did they reverse? What do you think? Well, I kind of told you in the title here, but well, they reversed. So this is a problem when I use activist titles in my papers, and I kind of give away the punchline. So this is what happened. So you can see 2011, 2013 is pre-ACA. 2014, 2015 is right when the ACA was implemented. It was implemented in 2014. And then 2016, 2018. So you see improvements when you look at the total, that's the first line. So you have 6.6% currently uninsured. That got better in 2014, 2015. It went down to 4.8%. And then it ticked up in 2018. And actually that difference between 4.8 and 5.1% might seem non-significant. It's 300,000 kids. So we have around, the total number of uninsured kids nationally is around 3.7 million. A lot of kids. That's bigger than something like 41 or 42 states. It's bigger than the size of 40-something states. Interestingly here, what do you see for the Latino kids at the bottom there? They continued to improve. Right? So while all the other kids, white kids and black kids, reversed, the Latino kids continued to improve, but they still lag behind. Right? And part of it is because they had so much more to come from, right? So their insurance rates before the ACA were really, really horrible. So they were lagging way behind. So now they're just kind of kicking up. And then look at this. So we know that health insurance is just one piece of the access to care puzzle. So what do we see here with well-child visits? They actually got better, right, for all groups. So why do you think that's so? So you see insurance coverage getting worse overall, and for white and black kids. But for all kids, well-child visits improved. Does you have any ideas? Well, the ACA, I'll give you a little hint. The ACA has some requires some essential preventive visits for kids. So things like immunizations. And so we speculate, we can't test with the data, but we speculate that these kids are really going in for immunizations where they don't need insurance coverage. And that's a big component of the ACA. Another thing that we don't talk about, and we talk about because we're public health professionals and nursing professionals and social work professionals, but in terms of the lay media, they focus just pretty much on the marketplace exchanges and the premiums of the marketplace exchanges and a little bit about the deductibles. The ACA is so much more than the marketplace exchanges, right? It's Medicaid, it's population health, it's improving healthcare systems and accountable care organizations and community engagement and all these great things that we talk about at the university and that they do in practice in public health, but the media never really talk about that. Okay, all right, so I just want to check the time here. So this is a paper that just recently came out in medical care. So we had a paper that came out in 2007 that used California Health Interview Survey. Excuse me, just as a footnote, the California Health Interview Survey is a large statewide population-based representative survey. It's now done, it's done yearly. They interview about 20,000 people every year. It's a telephone survey. They get decent response rates for a telephone survey. It's not great, but it's pretty good. And then they have weights to make it representative. In 2007, we just had a simple question using, and by the way, so CHIS is the California Health Interview Survey, CHIS, is the only large population-based study in the United States that has measures of documentation status. So if you want to have unbiased probability statistics on the undocumented, you have to go to CHIS, and it's only in California. And we just wanted to know, we were hearing, this is back in 2007 when the undocumented was still undocumented immigration was still a very polarizing political topic. We just wanted to know, and there was in the media you were hearing a lot about the undocumented immigrants were the result of safety net hospitals and clinics closing throughout the United States because they were burdening the healthcare system. And, but then of course if you go to the literature, there was no evidence for that. But that was part of the popular political dogma, which was that the undocumented were causing our hospitals and our clinics to close. So we just wanted to know if that was the case. And of course, in the 2007 study, we found actually they don't use really any healthcare, and about 40 to 50% of them have some form of insurance coverage. Some of them are, some of it's through the states, some of it's through employer-based, but they had insurance coverage. So this notion that the undocumented immigrants come in and they just, are a burden on the system and they don't pay. And then when we do qualitative assessments, we talk to clinic administrators, they say, all the immigrants who come in, the undocumented immigrants, if they're uninsured, they're the ones who are much more willing to come in ready to pay. They want to pay. So that was some interesting stuff that came out of that work. So we just wanted to reanalyze the data. And lo and behold, we find that the undocumented still, they have worse access and utilization of care, which is not so surprising. And these are adjusted analyses. So I'm not going to go through each point, but the patterns are basically for each indicator when looking at having a usual source of care, the doctor your insurance not being accepted by a doctor, having any ED visit, any doctor visit in the past 12 months, and the number of times a doctor saw you in the past 12 months, the undocumented fare worse than the other groups. And this was the first time using probability study where we were able to look at physical and behavioral health. And without going through each one of these, so these were looking at chronic diseases like obesity, overweight, high blood pressure, heart disease, and then whether or not they had psychological distress, they needed help for emotional problems, ever seen a mental health professional. The undocumented did better on all these indicators, meaning that they had fewer physical and behavioral health problems than other immigrants. So, and then we asked, and then among those who had a behavioral problem, they were also less likely to be able to get help for those problems. So they didn't have health insurance that would cover it, and they didn't enter into treatment, and they didn't get help because of the behavioral health problems. I was going to say one other thing about this. So an interesting observation here is that they have better physical and behavioral health, which isn't so surprising. It's a healthy immigrant effect, really. Although, recall the Pew data I showed you earlier, where 66% of undocumented Latinos are now in the US for 10 years or longer. So there's that spin on it that we still have to kind of explore. But they were less likely to rate their health as excellent or very good. So they were healthier in terms of physical and mental health, but they didn't rate their health as well as the other groups. And so in the paper, we speculate as to why. So now I have a few minutes remaining, and I want to make sure I release some time for Q&A, but I just want to get briefly into some policy dilemmas. So my colleagues, Hector Rodriguez, who actually at one point was on the faculty here at the University of Washington, and he's now at Berkeley, and Arturo Vargas Bustamante, who's a colleague of mine at UCLA, rewrote a few years ago on policy dilemmas for Latino healthcare and implementation of the Affordable Care Act. So one of the things which I alluded to earlier is that we're starting to see a growth, significant growth across the country of Latinos, but particularly in states that have not expanded Medicaid as part of the ACA. And this is problematic for a lot of us. This is problematic not just for Latinos, it's problematic for everybody in the state who's working poor. But what we're seeing is a growth, especially in Texas. I mean, Texas really should be ashamed of itself, for doing what it's doing right now in the courts, given their population demographics, their high uninsured rates, the vast number of Latinos who live in that state, et cetera. And also, I mean, you see it in the South, you see it in the Midwest. And also, being able to offer benefits to undocumented immigrants. California is one of the first states to start experimenting with providing health benefits to undocumented immigrants. They actually had put a federal waiver in to try to allow undocumented immigrants to participate in the marketplace exchanges, but without subsidies. And this was right before the 2016 election. And once the election didn't go the way people thought California was hoping it would go, they then just scratched the whole thing. But now they do allow youth and young adults who are undocumented to benefit from California health benefits from Medi-Cal. That's the state Medicaid program. And then I don't know if you guys heard of it. I mean, a few months ago, this was it's actually, I don't know where the status of it is now. It's probably been stayed in the courts. But the government has, the US government, the executive branch has tried to change the implementation and definition of public charge. So public charge is when you are liable to become a public charge, is the term used in the United States to classify prospective immigrants who are denied entry to their disabilities or lack of economic resources. And it really hasn't been enforced widely historically. It's been around, I think, on the books since the 1800s. And now the Trump administration would like to revive the public charge and also include public assistance, including Medicaid and SNAP, which would largely impact youth and families. And they could, it could be used against providing benefits to youth who are here legally authorized or who are US citizens. So that's quite alarming. And I showed you here, this was from the Center on Budget and Policy Priorities. How many kids would be disenrolled who would lose their health benefits as a result of changing the definition of public charge. And then, of course, so this is just, I wrote an article in the Philadelphia Inquirer a couple years ago about, children in cages, and we've all seen this, and this is, some horrific part of our history in the country, and then the impact that has on the health of families and also on being able to engage families into healthcare. And then finally, I'll just say, the Latino population is here. So, it's kind of like, it reminds me, you know, when I was in college, there was a phrase we'd go, we're queer, we're here, get over it, you know, and population is here, get over it, you know, we have to deal with it. You know, we, as a society, we need to make sure that Latinos are healthy, that they're integrated into society, that they're respected, and that we treat them with dignity, and that we value health as a human right. And with that, I will open it up to questions.